This is a case of Heller's cardiomyotomy and the importance of anterior vagus and intraoperative endoscopy. So, in this particular patient, with a patient in modified lithotomy and leg split, I have introduced the trocars. Liver is being retracted by a tooth forceps. I have started the dissection from the pars flaccida, and when I am proceeding towards the right crus, the caudate lobe is falling onto the right crus. So what I did was I used the left hand forceps to retract the caudate lobe and then took an incision and tried to dissect. However, the plane was not proper, and hence what I did was I went a plane which was one layer lower, and now you can see the planes dissecting very easily, the soft fluffy planes like sponge. So you have to go into this plane. You can see the aorta lower down, and now I am dissecting superiorly and anteriorly, making sure that the anterior vagus goes down by this maneuver, so that when we are cutting the peritoneum, we are not taking the anterior vagus. Having done that, I turned my attention to the left side. The adhesion of the stomach, the bare area of stomach, is now being freed. The left crus is being pushed away. A plane is being created between the esophagus and the left crus. We are not going too low down so that the pharyngoesophageal membrane is preserved. Having done that, I have now taken the pad of fat which is there at the cardia, so that when we are taking the incision on the stomach, this pad of fat doesn't come in the way. This is one part. And secondly, the anterior vagus, which is just below this pad of fat, needs to be preserved, and this is where the anterior vagus is. Now, if we take an incision which is on one side of anterior vagus, then the cardiomyotomy may become skewed and may keep on going to one side rather than staying in the midline or in one line. So what I have done in this patient is I have taken the anterior vagus, dissected it, and so that I can keep it on one side, and once it is pushed onto one side, my cardiomyotomy can be taken in one line. And this is a measuring tape just to make sure that we understand where our landmarks are and where we are going to start the cardiomyotomy. So we started just above the OG junction, which is the area which may be pretty easy. That's not the case in this particular patient. The circular fibers are tethered to the underlying mucosa, so I went a centimeter above so that I could pick up the circular muscle fibers, and then we can easily tear them apart. Holding the circular muscles with left hand, now I am creating a plane between the mucosa and the circular muscle fibers, and it's a pretty easy plane, especially if the patient has not undergone any balloon dilatation or any botulinum toxin injection. So here we are taking the cardiomyotomy superiorly. How far should we go? About 5 to centimeters is what I would advise, because that could be the length of the lower esophageal sphincter, not more than that. If we perform a slightly longer cardiomyotomy, there could be a few other complications which I will talk about later. So the end of cardiomyotomy, or to make sure that all the muscle fibers have been taken, the one way to visually accomplish that is to see the mucosa pouting out. On the esophagus side, there are no crisscrossing vessels. There is less vascularity of the submucosa. Always have a gauze piece side on one side so that one can mop, delineate the mucosa well so that you don't accidentally injure the mucosa. There's no need to use any energy source. And here we are easily putting down the mucosa, and we are almost at the top end of the cardiomyotomy, and you can see we are in a straight line, we are going superiorly, the mucosa is shining. Once we come down, we have to make sure that the teasing is such that we take only the circular muscle fibers and nothing else, and we leave the intact mucosa as it is. The mucosa should be shining at us. This is OG junction, and below that would be stomach, and this is where the tricky part would be. It is more vascular and there is more bleeding in this area. You have to make sure that you hold the cut muscle fibers in such a way that only the muscle fibers are teased away. I then performed an intraoperative endoscopy, and what I found was at the lower end there are still certain fibers, possibly the oblique fibers, and we can visualize them again here. So this is where the small ring was. We kept the endoscope at the same position and tried to visualize, and there you can see the oblique fibers which have not been taken down completely, and this possibly could lead to recurrence of the achalasia. So what we did was we went in again and we picked up fiber by fiber, teased them, cut them, so that now we have a wide OG junction, and we repeated the endoscopy to make sure that we have completed the cardiomyotomy completely. Having done that, we then performed a leak test, and then we went ahead and performed the Dorr's fundoplication. So we have to make sure that the Dorr's is not twisted, otherwise the OG junction will get twisted and the patient may have dysphagia, and one may think that this is recurrence of cardiomyotomy. You have to make sure that there is no untoward pull or twisting on the esophagus. So here we have taken the superior stitch. We use the left hand forceps to hitch up the stomach so that when tying the suture doesn't come off. And here we are repeating the same procedure on the left side. You are seeing the left hand forceps gently retracting the caudate lobe, and that's the completion of the cardiomyotomy. Thank you.